We're streaming live globally from now. We welcome you, and we particularly welcome people who are dialing in from all over the world. So let me explain who I am. I am Professor Beverley Hunt. I'm the founder and also medical director of Lifeblood, the thrombosis charity that's leading today in putting on this conference. And sharing in the leading is...
I'm David Fitzmaurice. I'm an academic GP, which is probably an oxymoron, from Birmingham. And I'm here representing anticoagulation in practice. I'm the past chairman of that organisation and also the National Centre for Anticoagulation Training.
And we're also supported today by the British Society of Haemostasis and Thrombosis, and we have their president somewhere in the audience, Dr. Henry Watson. So, why are we here? What is World Thrombosis Day all about? Can I have the first slide? Thank you. So this really is an unprecedented, fresh start to try and encourage awareness of thrombosis as an issue globally. And the aim of the World Thrombosis Day steering group is to try and engage with organizations, patient groups, and health professionals worldwide so that we can increase awareness of thrombosis. And we have to date more than 175 organizations signed up. Meetings such as this are taking place all over the world, and there are press conferences through the day in different countries. And this has been led by the International Society for Thrombosis and Haemostasis. So what are specific aims today? Well, World Thrombosis Day is focusing on the fact that thrombosis is a major cause of death, and we're going to hear from Lord Professor Kakar later about the global burden of thrombosis, but we're specifically focusing on venous thromboembolism, deep vein thrombosis, and pulmonary embolism. And we're focusing on 4 objectives today. We really want to reduce the number of undiagnosed and misdiagnosed cases. And we warmly welcome many patients here today. We're going to hear some of their stories, and you'll hear that misdiagnosis is a major issue in venous thromboembolism. We also want to increase the implementation of evidence-based prevention, particularly in hospitals, which is the major cause of blood clots. And we want to encourage healthcare systems to implement strategies to ensure they use best practice. And lastly, we want to encourage people to donate money so that we can improve research and best practice in these areas. And so we've picked today because it's a very special day. It's the birthday of really the father of thrombosis, who was Rudolf Virchow. He used to work in Berlin. He was the one that coined the term thrombosis, pulmonary embolism, and he did describe the 3 important things that cause venous thrombosis, which is stasis, sticky blood, and changes in the vessel wall. And we're going to hear later from Dr. Anders Cohen about venous thromboembolism. David, do you want to just walk us through the day?
Thank you very much. So, as Beverley's started to tell you, we're going to start with looking at what the burden of thrombosis is globally, looking at also the burden of venous thromboembolism. And then what I think is probably the most important part of today is hearing the patient stories. So we've got 2 patients who are going to tell us their experience of living and experiencing thrombosis, which I think is always very humbling, but also gives us great insight into what the real issues are. At lunchtime, we've got various games in terms of putting stockings on, and Beverley can also tell you about if you want to take a picture of your leg and give her £1, she'll put a picture of your leg on the Lifeblood website.
Something like that, yes.
We'll also be hearing about the new agents which are available to replace warfarin now. So I think the things have really moved in the last 5 years in terms of both prevention and potential treatments. And then finally, a little symposium towards the end of the day around post-thrombotic syndrome, which we were just discussing prior to starting, is a much under-researched area, but is absolutely devastating for patients when they get severe post-thrombotic syndrome. So that's the flavour of the day. We do want it to be interactive. We want plenty of questions, and I would imagine Beverley's going to be quite provocative in her questions, because it says on here we've got to have a call to arms, so that will be interesting to see. So I should propose that we actually start?
Yes. So first of all, I would like to welcome to the stage someone else who sits on the World Thrombosis Day Committee, major organizer of this event, who is an international expert on thrombosis. He sits in the House of Lords, and he's just telling me he's going to go back this afternoon and be asking the government about some provocative medical research issues. This is Lord Professor Kakar. He spent many years working as a surgeon in the NHS. He has many papers to his name about venous thromboembolism. Professor Kakar, over to you.
Well, Professor Hunt, Professor Fitzmaurice, ladies and gentlemen, thank you very, very much indeed for this kind invitation. Before I begin, this is my register of interest. These are the principal companies that I've worked with in the last 5 or 6 years in terms of undertaking research and other roles I've played with them. And of course, as your chairman has indicated, I'm a member of the steering committee constituted by the International Society on Thrombosis and Hemostasis to prepare for this World Thrombosis Day. Now, of course, the objective of World Thrombosis Day is principally an emphasis on venous thromboembolism. But what's sometimes forgotten is that thrombosis in general, the occurrence of a blood clot in a blood vessel, occluding potentially the lumen of that blood vessel, occurs both in the venous and arterial circulations. And there is certainly substantial interest in the problem of arterial thrombosis, fundamentally resulting in acute coronary syndromes, in myocardial infarction, if thrombi occur in the coronary circulation, if they occur in the cerebral circulation, stroke, peripheral arterial disease, often neglected, a growing problem, is associated with thrombotic manifestations resulting in lower limb ischemia, potentially gangrene and amputation. And then, of course, we have another area of increasing interest, the problem of thromboembolic disease in both the venous and arterial circulations in patients with underlying malignant disease, cancer, an important problem. It's suggested that for certain types of cancer patients, maybe 1 in 5 will experience some form of thrombotic episode during the natural history of their cancer. And then, of course, we have venous thromboembolism. And why is it right for us on World Thrombosis Day to consider thrombosis in its totality as we start to ask questions about the burden of disease? Well, it's right because we increasingly recognize that whether thrombosis occurs in the venous or the arterial circulation, there are common risk factors, common pathophysiological processes that result in that thrombosis. Of course, in the venous circulation, we've always considered a blood clot to be very rich in protein, as the free-flowing proteins that make up the blood start to coagulate and form a thrombus. Whereas in the arterial circulation, we've considered the thrombi to be much richer in circulating cells, platelets, a platelet-rich thrombus. But when we study the pathophysiology, the mechanisms, the associated risk factors, what we see are that they are common to both venous and arterial thrombosis. And indeed, studies suggest that those who have had a venous thrombosis may be at higher risk at times in their lives of arterial thrombosis, and vice versa. So this is a common disease with variations in pathophysiology and natural history, but nevertheless an entity of vital importance in public health terms. Now, when we look at thrombosis in terms of the global burden, it's striking to see that 1 in 4 deaths, if you look at the statistics provided by the World Health Organization, are attributable to a thrombotic episode. either ischemic heart disease or fatal strokes. Thrombosis is an important underlying pathophysiological manifestation. Of course, in arterial disease, we have disease in the vessel wall itself, the narrowing of the artery due to atherosclerosis, the formation of plaques that rupture and stimulate the generation of an intravascular thrombus at the site of narrowing. But the ultimate pathophysiological event that results in the acute disease, be it the heart attack or indeed the fatal myocardial infarction, is an acute thrombosis. So too in ischemic stroke, a blood clot forming either in one of the chambers of the heart or indeed a similar process of acute thrombosis in a blood vessel is responsible for the vast majority of strokes. And why do we need to be concerned about this? Well, we need to be concerned about it because taken together, thrombosis in the arterial circulation and, of course, as we'll hear further during this day, in the venous circulation, form an important part of the now recognized entity of chronic non-communicable diseases. We recognize that there are a number of risk factors associated with the development of thrombosis in the venous or arterial circulations. But one of the most important in public health terms is that the manifestation of thrombosis, be it venous or arterial, is not exclusively a disease found in aging populations, but is certainly seen more frequently in aging populations in many circumstances. And with the changing global demographic, an aging population globally, and with other risk factors common to both venous and arterial thrombosis becoming increasingly prevalent in those aging populations, we face a public health crisis in terms of thrombosis in the coming years and decades, something that we need to be very sensitive to. And that's why days such as World Thrombosis Day are vitally important, because they help us all, as patients, as carers and relatives, as clinicians, as healthcare professionals, as policymakers, and those responsible for the delivery of healthcare systems, to be able to focus on a major problem and ask ourselves whether we're mobilizing the resource in a responsible fashion to ensure that we can help the largest numbers of those individual patients and populations for whom we have responsibility. Now, Dr. Ander Cohen, who is a great expert in the epidemiology of venous thromboembolism, is going to speak to you next about the burden of VTE. But what we know about venous thromboembolism is it has a devastating impact. At the time when patients who used to die as a result of hospital stay underwent routine autopsy, it could be calculated that for every 100 admissions to hospital, without any form of thromboprophylaxis to prevent thrombosis, this is many years ago, one patient would die from a pulmonary embolism. So 1 in 100 hospital admissions would have been associated with a fatal thromboembolic event. And that is a really striking statistic, that pulmonary embolism, a disease that we have researched so much in the last 30 to 40 years, where we've got many improvements now, both in understanding who is at risk, how to prevent the disease, and how to better treat the disease, is still associated with a very high mortality. These are data from an international registry on pulmonary embolism that suggest within 3 months of presentation with PE, nearly 20% of patients would have died. That is a devastating burden, and I'm sure something that will be covered further in our discussions today. But if you go beyond the acute burden, the risk of dying from fatal pulmonary embolism, there is, of course, the tragic burden carried by patients and those who care for them and their healthcare systems, society broadly, for recurrent thromboembolic disease after a first episode. And there are now very large data sets that suggest that some 20% of patients who have had a first thrombosis within 10 years would have had a recurrence, 1 in 5 patients. That, again, is a huge burden, something that we need to be very sensitive to. And as David Fitzmaurice mentioned in his opening remarks, we often neglect the long-term consequences of that first thrombotic episode, not in terms of recurrence, we've covered that now, but in terms of the late sequelae of a leg vein thrombosis, the post-thrombotic syndrome, which in 5% of patients manifests itself as ulceration, induration, and pigmentation, truly disabling venous ulcers that are effectively, for a large number of patients, incurable, or indeed the manifestation of having failed to prevent a thrombosis in the lungs, the thromboembolic pulmonary hypertension, seen in some 3 to 4% of patients within 2 years of having survived their pulmonary embolism. So the burden of disease is substantial. I mentioned cancer-associated thrombosis, and it's striking here. You can see the reported frequencies of symptomatic venous thromboembolism, where they're registered in large administrative data sets looking at utilization of healthcare resource for patients newly commencing chemotherapy with different tumor types. And it's really quite striking that in certain circumstances, within 3 months of initiating therapy to treat their cancer, 10% of patients here with pancreatic cancer have experienced a thromboembolic episode, a burden of disease that we don't recognize routinely in terms of our overall management strategies for patients with malignant disease, where the emphasis is to drive hard interventions to achieve either cure or effective palliation, whilst reducing untoward and unwanted side effects and symptoms that might impact on quality of life. Well, clearly one of the more important here is potentially thrombosis. But what about ischemic heart disease? Well, here I think there has been certainly more attention because ischemic heart disease, coronary artery disease, and cerebrovascular disease and stroke, between them represent the cause for 1 in 4 of all deaths in the world today. But what we can see, and these are data published by Salim Youssef and colleagues some 10 years ago, looking at the projected frequency for ischemic heart disease across different regions of the world. And what's striking is it's not only developed economies that are going to see an increase in the frequency of this major problem, but the emerging and developing economies that have vast numbers of patients where this type of expensive chronic disease is going to have a devastating impact, both socially and economically, and as a result affect the global economies as well. Now, what is quite striking about coronary artery disease is that we've done a huge amount of research. So we know what the risk factors are. We understand how to identify high-risk populations. We've invested a huge amount into improving prevention, both in terms of lifestyle advice, but also intervention in terms of, for instance, the use of antihypertensive medication, antiplatelet therapy, statins, and so on, to try and reduce the impact of the comorbidities that drive heightened risk for coronary artery disease and myocardial infarction and stroke. But even if we apply everything that we know to better prevent and better treat these patients, thrombosis has an ongoing chronic burden, with 1 in 5 of those successfully treated for their acute coronary syndrome dying within 3 years despite best intervention. What about stroke? Well, here I turn to the problem of atrial fibrillation. Atrial fibrillation is a heart rhythm disorder, but it's a heart rhythm disorder easily identified, and once identified, can be acted upon because it is one of the most important underlying predisposing factors for thromboembolic stroke. Now, why do we need to worry about this? We need to worry about it because atrial fibrillation is a condition seen in aging populations, and it's predicted to be seen more frequently over the next 20 or 30 years. If you look, for instance, in the United States, 10 years ago, about 6 million people had diagnosed atrial fibrillation. By 2030, that is predicted to be closer to 15 million people. All of those patients, or a substantial number of them, will have additional risk factors, easily identified, but in combination with atrial fibrillation, will heighten the risk for thromboembolic stroke. And why is that important? Well, we know that for those over the age of 40, there is a lifetime 25% risk of developing atrial fibrillation. In those who have atrial fibrillation, there's a 5 times greater risk of developing a stroke. And in those who develop a stroke with atrial fibrillation, there is a 50% mortality at 1 year. So overall, what we recognize is that thrombosis, be it in the venous circulation, in the coronary circulation, or affecting the cerebrovascular circulation, has a profound impact clinically for our patients and for those who care for them. But there's also a tremendous economic burden associated with thrombosis globally. It's estimated that the spend on managing thromboembolic disease in the United States is about $1.5 billion annually. The management of the post-thrombotic syndrome, the late complication of having failed to prevent deep vein thrombosis, has been estimated to cost our National Health Service many hundreds of millions of pounds a year. We know that when you look at the cost of managing stroke across the European Union, estimates suggest that some 38 billion euros a year are spent on managing this condition. And then if you try and determine the overall economic impact, not only the impact of managing the disease itself, of managing the individual itself, but the broader economic impact of managing a manifestation of thromboembolic disease, in this case acute coronary syndromes, it's estimated in the United States to cost more than $150 billion a year. So what we can conclude is that thrombosis manifests itself in many ways in both the venous and arterial circulations, that those manifestations are both acute with an acute burden, the presentation of an acute blood clot in the legs, a stroke or a heart attack, and then a chronic predisposition to disease over a long period of time, making thrombosis-related disorders one of the most important chronic non-communicable diseases contributing to global health burden. Can we address it? Well, the answer is yes. We know that providing thromboprophylaxis to patients around the time of operation will save 7 lives for every 1,000 operated patients. We know from decades of research with acute coronary syndromes that providing thrombolytic therapy, antiplatelet therapy with aspirin, more recently heparins and low molecular weight heparins and new generations of parenteral antiplatelet therapy will improve the outcome and reduce mortality for patients presenting with a heart attack. We know that in the long term, progressive improvements in antiplatelet therapy have helped both reduce mortality and improve outcomes in the long term for patients at risk of recurrent heart attacks. And we know that anticoagulant therapy against no intervention in patients with atrial fibrillation at risk of a stroke will reduce their stroke risk by 2/3 and reduce their risk of dying by 1/4. So as we move forward into contemporary healthcare, we start to consider how we can take this burden and act on it. And I was very taken by a talk I attended last week that talked about the 4 Ps of healthcare: to be predictive, to be preemptive, personalized, and participatory. And I think when we look at the magnitude of the thrombosis burden, the impact it has both on individuals, on healthcare systems, and more society broadly, we need to apply these 4 principles. And there is much we know already that can be applied in this framework, and there is much that we're doing currently with contemporary clinical research, experimental and translational research, which will help us over time better identify those at risk of thrombosis, preemptively intervene in those, both at risk of venous and arterial thrombosis, to reduce their risk and burden, to ensure that where they have developed a thrombotic episode, we can personalize intervention to achieve the best clinical outcomes. And of course, most importantly, and why this World Thrombosis Day is so important, ensure that we all participate in reducing our individual thrombosis burden, and we all participate in ensuring our healthcare systems can work most effectively for the benefit of the largest number of potential possible patients. So in conclusion, Mr. Chairman, it's clear that thrombosis represents a substantial burden of disease, that there are multiple manifestations. We're good at recognizing some of them, other manifestations not very good at all. But what we know is if we make thrombosis, be it in the arterial or the venous circulation, an important element, focus of our activities, we have tools available to us that will help reduce that burden and drive forward the very best opportunities and outcomes for our patients and populations. Thank you very much indeed.
That was an amazing summary of where we are globally. Oh, don't go away. Are there any questions? Does anyone have anything they want to ask? What should we be doing in the UK?
I think what we should do in the UK is what you have been doing in Lifeblood. I think it's vitally important that we continue as a community of healthcare professionals and clinicians working effectively and in absolute collaboration with our patients and with other organisations, with government, with policymakers, with our NHS, to highlight the problems that patients who develop thrombosis might face, ensure that there continues to be a responsible focus on this problem, and that what we really do is take everything we have learnt from decades of very, very thorough and meaningful research and ensure that we apply that effectively, getting research into practice for the benefit of our patients.
Thank you very much. One more question? Simon.
What do you see as the research priorities in thrombosis?
That's a very, very big question. We could spend a day discussing research priorities in thrombosis. What I would say is as we increasingly in medicine move to what we call an era of personalised medicine, we must ensure two things: that the general population or patient population applicable messages about risk assessment and prevention are not lost, but that we do more and more to understand why certain groups of patients, despite those interventions, do badly, where we can personalise, or we can drive our understanding to a better personalised level for those particularly high-risk individuals to get their outcomes to the level where we hope everybody would be.
Fabulous. I'm afraid we need to move on now. So thank you very much. We welcome to the stage Dr. Anders Cohen. Anders really is the international expert on the epidemiology of venous thromboembolism. He's done a huge amount of work and continues to do so. He's quite a challenging speaker and he'll have you thinking, I'm sure. Anders, over to you.
Good morning. Dear chairpersons, Beverley, thank you for setting up so much of the work that we enjoy in today. David, for your presentation, and particularly AJ for setting up the talk in such an erudite way. I work here, and so I just thought I'd show you a nice picture. And my job is to sort of fire you up before the call to arms. I'm sort of like the trumpet or the bugle player. So I'm going to do a bit of bugling, and I'm grateful to Beverley and David for letting me bugle about something that I've been banging on about for 20 years. Actually 20 years when I started sitting down with a colleague of AJ and mine, Bob Edmondson, and we spent many a cold winter looking at 21,000 autopsies at King's College. I'm going to talk a bit about drugs, so I'll just show you some disclosures of various types. I may even talk off-label. So what is the burden? It's two things. It's morbidity, which I'm going to deal with first, and it's mortality, which I'm going to deal with second. Some years ago, we worked on a incidence-based modified model where we modelled thrombosis throughout the EU and North America. And we published these two pieces of data, and we made an estimate of the morbidity and mortality in the EU and United States, working with John Haidt from the Mayo Clinic. And we came up with figures that people weren't entirely comfortable with. They thought that's too many. You know, you can't have 500,000 deaths related to venous thrombosis in the EU. We're only losing 5 million people, 6 million people a year. You can't have 500,000. And of course, this data was then taken here and compared with similar figures that looked maybe 60,000 deaths in the UK, maybe 25,000 deaths we could do something about. So we published this data, but because we wanted to alert people that this was a much more common cause of death than people suspected. And at the same time, we looked at other causes of death in the EU and we published this data. And this sort of theme was taken up fairly broadly, that you might be wearing a little pink badge for breast cancer or a blue badge, red badge for HIV/AIDS. But if you wore a sort of purpley badge for blood clots, people would say you are a clot. You know, they're not really interested in blood clots. And that's one of the problems we had. But we also estimated the cost back in, whenever that was, 2007. And we thought that in the EU it's about 3 billion. But more importantly, we looked at the extent of